Hello and welcome, colleagues. We're going to be starting in just a couple of moments. My name is Tom Fowler, and I'll be co-hosting along with Nadav, who will also be doing the introduction. But we're just going to give it a couple of moments for anyone else to join before making a start. So if I make a start, I'm sure that some more colleagues will join, but we're up to 46 people, so that feels like a good place to start. So first off, if I could introduce myself, I'm Tom Fowler. I'm Deputy National Director of Health Protection and Screening Services in Public Health Wales, and I'm agreed to sort of co-host this presentation. This webinar. I'm here representing IANPHI, which, as I'm sure many of you will know, is the International Association of National Public Health Institutes. And within IANPHI, there are a number of thematic committees that look at different and key areas. And the inspiration for this webinar is very much the conversations and discussions of the Pandemic Preparedness, Response and Recovery Thematic Committee, where, as part of those discussions, the issue around ethics and the implications of those was really coming out of reflections around the COVID-19 pandemic. So I'd just like to start off by asking my current boss, Meng Kaur, if he wouldn't mind just saying a few words about the thematic committee as he is chair of that. Meng, if I could bring you in.
Yeah, thank you so much, Tom, and thank you for you and Nadav for organizing this webinar, which is a really important topic that we agreed in the Pandemic Preparedness Thematic Committee was an area of interest to many. And I can see from the 50-odd participants we have, it's clearly created some interest here. For those of you who don't know, IANPHI has 5 thematic committees, of which the Pandemic Preparedness and Emergency Response Thematic Committee is one of the more recently established thematic committee, and I took over the role of chair about 3-4 months ago. We have agreed some priorities for the work stream, and we were keen to address inequalities through a response lens and also an emergency preparedness lens. We wanted to understand and strengthen the role of public health institutes in emergency response. And we also wanted to ensure that should we have another pandemic in the future, that we are better joined up in terms of getting information for action. And finally, we wanted to strengthen our data systems for data sharing for pandemic preparedness. So I think the issue around ethics really fits into that overarching framework so that we can be a bit more responsive to the threats that the pandemic will bring, but also have an underpinning framework around our ethics and our approaches to all the things we might do slightly differently from business as usual that require the consideration. So I'm very, very excited to hear from the speakers today and the discussion that follows. So thank you, Tom and Nadav. Back to you.
Thank you very much. And I will seamlessly segue and hand over to Nadav now, who is also going to introduce us and take us through the format of the meeting as well, or the webinar. So Nadav, over to you.
Thank you so much, Tom. And of course, thank you, Meng, for giving us the opportunity to have this really important webinar that we hope will be just the first from a series devoted to the question of pandemics and public health ethics. So my name is Nadav Davidovich. I'm a public health physician. I'm from School of Public Health at Ben-Gurion University. I'm also an executive board member of ASPHER. For those of you who are not familiar with ASPHER, so it's the Association of Schools of Public Health in the European region, the key independent European organization dedicated to improving, protecting public health by strengthening education and training of public health professionals for both practice and research, dealing with professionalization of public health workforce, capacity building, with now almost close to 200 member schools, and dealing with achieving the missions of education, training, scientific research, and service. Specifically, I'm the chair of the Public Health Emergency Task Force that was previously led by Professor John Middleton and was called the ASPHER COVID-19 Task Force. And I'm very happy also to say that we have this collaboration between ASPHER and the IANPHI. Of course, we are part of the working group that find the thematic working group that was leading to this webinar today. We're working with ASPHER and IANPHI working together on joint effort in agenda on public health workforce professionalization, including competency framework, core curriculum input from IANPHI, and most relevant to the session, also code of conduct discussion, and also the current focus on public health ethics, as was mentioned before, is likely to include more than just this session, many more things to share between the two organizations to engage on this topic together. Before I will present our speakers, I just want to say that the context of the discussion today is the new normal. So the new normal, actually, the term emerged even in the early 20th century after the First World War, but probably more known in our context related to the question of COVID and COVID exceptionalism that created the new normal that we need to learn to live with, meaning the change in perspective. Of course, many of things that happened in COVID were not new to public health experts, including the fact that health exists within a social and political context. But we thought that still, in this age of uncertainty, in the age of the new normal, that now it relates not just to pandemics, but also to many political processes, the question of social media and other things. We need to understand better what should be the role of public health ethics as distinct or complementary to bioethics that is much more clinically oriented. So this was the framework for the discussion and the preparation for today's meeting. What I'm going to do, I'll first present our three speakers today, all very good friends and distinguished experts in the field of public health ethics. We have first Dr. Farhang Tazib. He's the convener of the Public Health and Ethics and Law Network. I had the privilege of working with him on several things, including on solidarity in public health, migration and public health. He will be speaking on pandemic emergencies as the moral mandate of public health. Then we have Professor Alison McCallum. She's a visiting honorary professor of public health at the Centre of Population Health Sciences, the University of Edinburgh, Scotland, and chair of ASPHER Public Health Emergency Task Force Vaccination Subgroup. We're working very closely on issues on inequalities and vaccination policies. And finally, Dr. Maya Peled-Raz. She's the head of the Bioethics Division, the School of Public Health, University of Haifa, and she's also a lawyer. She will be speaking on public health control measures. So as you see, we have a very diverse group of speakers. We were supposed originally to include also elements related to public health ethics regarding research in pandemics. But finally, we decided that also because of personal reasons that this would be probably our next theme for a meeting on public health ethics. So we will start by each presenting about 15 minutes. After each presentation, there'll be an option to have very short questions, mainly from clarifications, but leaving the more in-depth question for the end of the presentations. After the three presentations, we're going to have several questions from me and Tom, and also the option for each presenter to react to our presentation, and then we'll open for a question. Please also, if you want to raise something, you can bring it into the chat, including questions. And during the Q&A, if you'd like to ask a question, please raise your hand. So again, thank you so much, Tom and speakers, and also for Meng. I'm really looking forward for this important discussion. And we're going to start first with Farhang. The floor is yours. Thank you.
Thanks very much indeed. If Ines, you could kindly help me with the slides because I've got technical issues with my computer. Ines, it's a great Ines can. Thank you very much. It's a great pleasure actually to be part of this particular webinar. These are turbulent times, and particularly with respect to pandemics, the pandemic, if I could have the slides, please. The pandemic treaty has sort of stalled, and we'll only get 4 days in the World Health Assembly in May to deal with it. And there's also political turbulence, and there's actually reports of lots of little potential issues for pandemics. So it is quite an apt time for us as a thematic group and I'm delighted for IANPHI and ASPHER for inviting this. I particularly want to focus on the perspective from a public health professional perspective, because it is one of our key areas of work. And public health really became in the spotlight even more during the pandemic. And it is one of our core competencies to do that. And I remember as a local director of public health, how we did years of pandemic planning. Every 6 months, we used to have mock-ups and all this sort of thing. But I also do remember that once COVID came, perhaps it wasn't so much help. But it is an important time for us. So the main question I want to see is what is our mandate as public health people? Who are we, and what should we be talking about in our thematic group? And do we really care about ethics? Next slide, please. When I was preparing for this, and I shared the advert for this, one of my colleagues, Professor Jim Thomas from the States, University of Chicago, he says, fine, make sure you plug his website which he specifically developed during COVID as some resources, ethical reasons. And he said the reason he did this, because there was a collective loss of memory about several efforts to articulate ethical principles. And this is a very, very practical website with Jim Thomas, who's actually one of the founding members of the Public Health Ethics and Law Network. And I also know Professor Joseph Mafutsa Mango from University of Malawi, who's an ethicist, who's also part of this group. And so I've done my plug, and I'll claim my fees later on. Next slide, please. Next slide, please. I think to start the beginning, it's important for us to recognize that if we don't care, we should be caring about ethics, because as the Lancet Commission on Culture and Health pointed out in 2014, then systematic neglect of culture and health and healthcare is the single biggest barrier to the advancement of the highest standard of health worldwide. And this was a very Lancet Commission report for quite evidence-based how important this issue is. And the other major point, which I want to sort of demonstrate through this, is public health is not merely a technical discipline. In our approach to pandemics, we can do all the numbers and facts business, but our norms, values, belief, and the way we as individuals, institutions see the world also matter, as highlighted through different policies adopted. And so it is fundamentally important. And with the changing political landscape, for example, in the US about different values, we can see quite clearly if certain things should happen, it'll have impact on health. Next slide, please. And the other issue, which I just want to stress again during this particular conversation, is that our mandate as public health leaders and physicians and professionals is to ensure the protected health of the population through art and science and through organized society. But this is inherently a moral issue. The reason with it is that it carries with us obligations to care for the well-being of communities. Doctors swear the Hippocratic Oath. We as professionals go through training and development, and it implies certain powers to carry that mandate. And during my conversation, I just want to largely talk about how we exercise this power, because that's at the crux of public health ethics, is how you do things, how you ought to do things. And this is at the heart of what ethics is. So that's going to be largely my pitch in terms of talking about pandemics. Next slide, please. As we all know, pandemics is about all people, all, demos, all people. But it's interesting from a health perspective, the word has been used for about 2,800 years, but the health implications were used because Plato used to talk about pandemic of love, and our famous Galen, the heart bloke, used to talk pandemic of famine. But only at the beginning of the last century, when pandemics began to be used as an epidemic on infectious diseases, as a sudden increase in cases spreads across large regions, for example, where it affects a substantial number of people. And when we talk of health and pandemics and so on, the Spanish flu, the HIV pandemic, swine flu pandemic, and of course the COVID pandemic, which a lot of us experienced, which I'll talk about a little bit more, are sort of classic pandemics, and where the definitions with infectious disease largely came into our narrative as public health professionals. Next slide, please. I just want to take us back to the Ebola outbreak, because many of us actually experienced the global public health emergency of concern by WHO, particularly in 2019. There was also emergency concern in 2014. And I remember very well how wonderful, as public health physician, we did all these charts measuring the number of cases, the death rates. And in fact, just for historians, it's important that Ebola is described as the most deadly disease in history, are far worse than estimated bubonic plague. So it is a major cause of issue. But I remember in 2014, very few people actually took any notice of it because it didn't affect us. It affected the other side of the world. And in 2019, we only took notice of it when the first European was shipped, and suddenly things beginning happening. And that's quite important in terms of according what ought to have happened in terms of preparedness and how we were moved to act as public health leaders around the world. Next slide, please. I also recall very, very well this picture in the Liberian newspaper when we were talking about quarantine. It seemed a far-off thing before it came to Europe. And this was the headline: this is not public health, this is violence. It talks about quarantine, and there was a lot of learning at that time, which we didn't hook onto. It's only when COVID came in that these sort of images suddenly became real, when China and other countries began to do interesting stuff. Next slide, please. After the Ebola outbreak, there were a lot of reports. UNICEF, UNDP, a lot of organizations began to develop reports on learnings. You know, we love these sort of evaluations and what was our learning from this. And Smith and Upshur actually did a review of all these different learnings, which cost millions. I mean, UNICEF did a learning, which was very well commissioned, a wonderful report. A lot of these reports were about dramatic call up. Wake up, everybody. We had an epidemic. And the summation of this article from Smith and Upshur in 2015 was largely they framed this as moral failures. The issue of Ebola, they said, had a lot of technical issues we could have done better. And their conclusion was we can't fiddle around at the margins just considering these technical issues. This need to be, we reflect on our repeated moral failings and committing ourselves to a set of values that engender approach to the global public health emergency and embody a sense of solidarity and global justice. We've heard this before, but I mean, their conclusion also was, why are we happy to recurrently have dramatic wake-up calls? Because historically, all these different outbreaks and so on have always had reports, wake-up call, and it costs us a lot of money and expertise in our time doing these evaluations. Next report, please. Next slide, please. Their argument was, if the global community is willing to spend over $4 billion on the Ebola response on its own, and these were calculations from UNICEF and so on, we ought to also be willing to commit the equivalent or more on health systems improvements which will help to prevent such outbreaks. Why was it we didn't take any attention to this till suddenly someone, a European happened and came to this? Why are we happy to recurrently have dramatic wake-up calls but reluctant to answer them? Next slide, please. There was also a wonderful paper around Ebola doesn't fall on the sky, and these epidemics and pandemics just don't fall out the sky. Do we just we have to look in Chinese labs to look where Ebola come from, or do we look at more systematically where pandemics originate from? These things do not fall out, even accidents, you could say, do not fall out of the sky. There are always reasons, and the things we ought to have done. And the four conclusions from this paper, which became a large report in itself, was international actors should conceptualize crisis beyond merely addressing direct physical causes. In other words, getting a pathogen which infects people and then measure that and look at the death rates on that said. It must remedy structural violence, societal issues which actually originated. The other major issue, because of links with many countries in Africa and so on, is that there's a complicated relationship with infectious diseases and conflict, which actually does deserve some understanding. How often have we discussed in our thematic groups around role of conflict and so on? Us Europeans, since Ukraine instead perhaps, but there's a real issue we need to really recognize public health as a global thing. And there's real issue around shared international responsibility norms that should be developed as part of our ethical normative discussions. Next slide, please. It's interesting that Maxwell and Upshaw, when the COVID outbreak, WHO set up a ethics group, and Ross became the chair, and Maxwell Smith became the secretary of this group in the WHO group. And their assessment in 2010 was sharing some of the learning from the Ebola outbreak with the group, and they published a paper that the most powerful lesson learned from the 2013-16 Ebola outbreak in West Africa was, we do not learn our lessons. Our past failures must be understood as moral failures that offer moral lessons. Unless we appreciate we have a defect in our collective moral attitude towards remedying conditions that precipitate the emergence of outbreaks, we will never truly learn. This is the beginning of the pandemic. And again, as a group, reflecting on ethical issues and dimension, I think these reflections are quite important. Next slide, please. In the next few slides, I just want to reflect on the COVID outbreak, which many of us were participated in globally, wherever we are, whether we're in Malawi or wherever. And I think the pandemic provides a stress test for the public health system. I'm sure we all remember that at the beginning of the pandemic, how people clapped on their balconies, they sang sweet songs. I even got a cake outside the door, and we were real heroes. And I remember when the pandemic first came to northern Italy, a group of Chinese people came with some supplies of masks and so on in Milan airport. And they rolled out this, we are waves of the same sea, leaves of the same tree, flowers of the same garden. There was a real fraternity around public health and the population at large in light of these threats. And we were largely seen as heroes, and we did fantastic piece of work. There's no doubt about that. But within 18 months, next slides, things seem to have become sour. In the States, paint began to be daubed on people's houses. There was a lot of stress within the system because we did not agree personally about some of the government and public health professionals. We came as loggerheads. Independent COVID groups began to occur in Europe. And as the politicians went on their pulpits, we became uncomfortable with some of the message. There was a very robust piece of work done in the UK about public health professionals, where 64% of the public health workers in the UK noted they had experienced moral distress during the pandemic, and 14% had actually moral injury with the significant psychological issues. As public health people, of course, such issues are not new. I was doing a historical analysis of this, and in 1848, long time ago, the Times reported on odious creep of nanny state during cholera. Cholera was rife in those days, and editorial in the Times how they prefer to take our chance with cholera and the rest rather than bullied into health. There's nothing a man hates so much than being cleansed against his will or having his floors swept, his pet's dung heaps cleared away, rather than being bullied into health and so on. So we have a history of professionals where our professional mandates seem to be at loggerhead, and accusations of nanny state and so on continue. Next slide, please. Of course, the other reflection around that is, as public health professionals, we did technical miracles. There were technical miracles. Development of the vaccines. Developing a vaccine within 18 months was indeed wonderful work, technological developments and so on. But at the same time, of these wonderful technological developments, they were real moral catastrophes, as the WHO, Dr. Tedros, the DJ, pointed out. Moral catastrophes in terms of distribution of vaccine and the way governments and policymakers behaved towards humanity and our fellow men. So there's a real balance, the best of times and the worst of times, as Dickens posted. In the light of this, there have been a number of ethicists who've commented on what needs to be done in preparation. And just 3 bullet points from that evidence we can discuss it later. Firstly, integration of ethics into policy making right at the beginning. It's no good to bring ethicists right at the end or to have them as need be. They need to be right at the beginning so that all policies are ethically informed right from the start. Second recommendation has been practical implementation of values such as solidarity and social justice. And thirdly is professional, including our own, and institutional ethics, capacity building in public health organization and agencies at all levels. There is still evidence that over 50% of public health trainees have come out of their training without adequate training in ethics and law and so on. So this capacity building applies to everybody, including us. Next slide, please. The other issue which came up during the pandemic is that the winner of the Pulitzer Prize for explanatory reporting for his coverage of COVID was won in the States by Ed Young. And it's largely for this article where he calls for public health to discover its purpose. In his article, he says how public health took part in its own downfall. The field's future lies in reclaiming parts of its past that's willing to be abandoned. He says public health has become far too technically orientated and not lobbying enough for social reform and so on. And this attracted huge attention because it was published in Atlantic newspaper in the States. Next slide, please. Of course, this is nothing new for us in public health. As you know, Richard Horton, in a number of articles, he has criticized public health people, I don't know whether rightly or wrongly. And for example, in 2011, he said there was a time when public health was driven by public health articulated values. Its leaders were concerned about social reform and political change. Public health is a science of social justice, overcoming forces that undermine the future security. It's time for those leaders to discover current and example. I'm not being negative in this, but this happened during, this is part of the critique of us. Do we care about ethics? And next slide, please. Of course, public health is defined by its values. We're driven by, many of us joined the protection because we wanted to genuinely work through organized efforts of society, the population issues, and we're driven by our values because we want this change, tackle inequalities and so on. But do we bring this stuff into practice, or do we do it on the side? What do our conversation consist of? Is it merely technical issues, or do we do our broader mandate? Next slide, please. As part of the WHO group, the WHO group is Global Research and Innovation Group. As you will know, there were 6 values which they highlighted: solidarity, equity, trust, autonomy, equal moral vulnerability. My basic question is, how often do we discuss this in our thematic group? Because these values were designed. And the more important question is, these are not just philosophical issues which we do on our armchairs for hobby or part of a webinar. What does this actually mean for practice? And I hope during the discussion we can talk about this. The final slide, therefore, is next slide, please. Maria Vankova, the director of the Epidemic Pandemic Preparedness, was interviewed by The Guardian on 2nd of January, a couple of weeks ago. And she was asked the question, are we ready for the next pandemic? She said yes and no. The yes was, we've never been better positioned in terms of our expertise, technology, and data systems. You know, our competence technically is never, we can draw these lovely charts of death rates, have all these numbers and wonderful things. But we're absolutely not ready because of the difficulties and trauma we've all gone through as professionals, and other outbreaks around the world, such as the war, climate change, economic crisis, and the so-called polycrisis. I think pandemic, if it doesn't fall from the sky, there's something which keeps on making it happening. Climate change doesn't fall from the sky, it's not an accident. And we need to reflect on this as a group considering ethics. What is it? And the final slide is largely to the next slide, please. And the next one, please. Next one is at the 17th. No, the one before that, please. The one at the 16th World Congress, which the title "Public Health for the Future of Humanity: One People, One Planet." Please, there was a statement which all the schools of public health, IANPHI, everybody seemed to have signed it, which highlight. This was the beginning of the pandemic, where the World Congress was held online. And the statement was signed by everybody, said we need ethical, courageous leadership, we need to recognize interdependence, interconnectedness, need for unity, and that global collaboration, coordination during a pandemic out of both an epidemiological and a moral duty. And it's interesting, at the most recent one, there was a coalition of partners, next slide, final one, please, where there was a number of workshops on ethics, and there's now thankfully a coalition of people working through the public health ethics network who are trying to get more action of this. So I think my 15 minutes, so I thank you very much. I hope during the discussion we can sort of consult on some of these issues. Thank you. You can take the slides away. Thank you.
Thank you so much, Farhang. Indeed, lots to discuss, including probably the question of political will. So I don't see anyone with a pressing question. So let's move to our next speaker, Professor Alison McCallum. The floor is yours, please.
Thank you very much, and I'm delighted to be here, and I hope that my talk will follow on nicely from Farhang's. So I'm going to talk about my thesis is that public health advances by successive redefinitions of the intolerable, and I'm going to use vaccine inequity, emergencies and equity as examples. Oh. So I'm afraid my slides are not advancing. Here we are. So my proposition is that we are all, as public health academics, educators, practitioners, attempting to do more good than harm in our daily work, in challenging and complex systems and environments where there are competing goods and harms. But the evidence before us of global vaccine inequity, the slide at the bottom left, vaccine dependency, so we rely on vaccination because we haven't got the basics right in terms of addressing poor health, levels of multimorbidity, social, structural, and relational inequities, or addressing practical and relational barriers to accessing and engaging with services. These things are all telling us that there are gaps in our approaches to public health ethics, to turning what may be internal values into practical action, particularly in emergencies, and that gets in the way of our making progress towards the Sustainable Development Goals. And the picture on the bottom right is from a short film by a Scottish filmmaker, which looks at the daily lives of people on precarious contracts. She has other films about people who are new migrants and people who undertake unprotected, dangerous work. So these are people that we often forget about. Now, we know that populations at increased risk of exposure to or from disasters and pandemics are that group that we forget about. People who experience life in liminal places, on the edge, at the border. That may be financially, it may be environmentally unsafe, it may be unsafe housing, it may be precarious work. They have limited access to material resources, income, practical stuff, and social resources. So alternatives to professional and third sector input in many settings. They don't necessarily have a network of friends they can turn to day or night, and they don't necessarily have even the one good adult that we talk about when we talk about child development. We have communities that experience discrimination and exclusion, and we see that writ large in our uptake of preventive methods. We know from work that we've done in ASPHER that people with disabilities had real difficulties accessing healthcare during the pandemic, despite legislation which should enable them to have equitable access. And we know that people from particular ethnic groups, socioeconomic groups, people in precarious work, people with multiple morbidity, found it difficult to get the help they needed in a timely fashion, either for their primary disease or when they became ill, or to access preventive methods. So when we design our responses, these pre-existing vulnerabilities, coupled with poorer intra-pandemic experiences and a long shadow of poor post-pandemic outcomes, particularly with the avoidable harm that came from pre-pandemic austerity in many countries, and we're seeing post-pandemic with conflict, with other outbreaks, with crop failures, with climate change. And yet our pandemic response, there is a chasm between that, how it's designed and what's required. And that reflects the chasm between those most at risk and those designing the response. And when looking at policy documents, we see very clearly this focus on technical solutions and public health people running about like, working all the hours to mitigate harms that come from policies designed elsewhere, rather than having the headspace and the time to be able to start thinking and using their energy upstream. So the people who are most vulnerable are also at increased risk of being designed out of responses. And that's where the gap between what we may hold as internal values, what we have in our training, and how we are having to think about public health ethics on a day-to-day basis, that's where part of the gap is. And that causes avoidable harm for everybody. In addition, we talk about things like vaccine hesitancy as being an individual phenomenon or something that affects particular communities or particular professionals. We forget often when we're thinking about our responses and thinking about the ethical frameworks that systemic discrimination and inappropriate responses to unmet need by institutions is a global problem. Structural violence in action at its broadest sense, but seen every day by experience of dysfunctional relationships between individuals, communities, and the institutions that are supposed to reduce the risk of avoidable, amenable death, disability, distress, and disease, and instead produce avoidable inequity and harm. Whether or not people are protected in theory, in law, everywhere we look, there is a gap between the ability to make a difference, the duty to make a difference, and what we're able to do on a day-to-day basis. So colleagues in Canada, Cardinal and Pepler and others have developed this terminology around the relational determinants of health as a principle, the foundation on which healthy, mutually respectful relationships are developed and sustained, and could be an embodiment of us helping to rebuild and change. These current and historical inequities cast long shadows over people's lives, experiences, and are manifest in the way they relate with us, and it's up to us to change. But these inequities and their shadows may be the only evidence of who is missing. So some of our specific learning from the vaccination subgroup, when we think about the right to health as a principle, we think about the requirement for non-discrimination. We think about the gaps in what we've seen around what we want to do, which is to treat and enable people to have lives worth living and lives of value. And we demonstrate that often in its absence. We think about structural factors, and we've seen in our work in looking at global vaccine inequity, looking at the behavior of companies and the countries who are largely vaccine makers, those who undertook the initial research, and those who have most to benefit, that there was that structural evidence of inequity. We see that still in the proportion of the population who received even one initial course of COVID vaccination, and we see it in other vaccinations for animals, for plants, as we do in humans. We see it in the lack of attention to climate change, in the offshoring of the consequences from high-income countries to low-income countries, which increases pandemic propensity. In addition to structural factors, which we see in every literature review, in every aspect of vaccination that we've looked at, And I'm happy to share some of the work that we're writing up at the moment. Power relations, thinking about those relational determinants of health. We see that in differential access and barriers to vaccination, particularly, for example, for migrant workers, for people who don't have access to the benefits of collective engagement and bargaining, who work in conditions where there isn't organisational justice. We see pregnant women unable to get time off for vaccination. We see people unable to take time off because they're not paid, or they don't have access to time off in case of side effects. We saw during the pandemic that some of the things that we had striven for as public health professionals in terms of working towards minimum income for healthy living, in terms of compensating people if they had to isolate or quarantine, were removed, and there were delays and gaps in the practical response. There were people who fell through the cracks because of the very tight definitions of eligibility, where you had to have a magic diagnosis, as someone described it to me, rather than all of the individual things that they had wrong with them that meant that they were at increased risk of harm. We've seen the issues around conflict, not just the structural conflicts that we're trying to think about how do we design ethical mass immunization without putting people at risk of physical harm, without putting people at risk of harm from the spread of disease, how we can make things accessible when there are narrow time windows to act. So conflict at that large stage and on the small stage with people experiencing microaggression and discrimination impacts on your capacity to act and interact. What people like Jan Gru, the disability academic, talk about as the extra cognitive burden. So all of these things we see, and they could be designed out. So when we think about vertical equity, we shouldn't be thinking about how do we design for people like us, which is what it often feels like. Think about co-design. We see this at very small scale in many countries, but it never gets long-term funding. The changes, the improvements learned never seem to make it into our strategic way of doing things and the way we organize our health systems. We have tools that we can use to help us with competing goals and intended and unintended consequences. So not just ethical frameworks that can help us, but practical tools like integrated impact assessment. So not letting governments off the hook when they think about cost effectiveness only in terms of the cost to business or the cost to the specialist services and not the cost to our population. So thinking about mandating high quality, integrated impact assessment so that we are clear about what we do, what we decide, what we revise, and how we mitigate harms that cannot be avoided. And when we think not just about autonomy, we think about non-domination. So we think about collective protection, collective ethics. We commit to closing that chasm between people who are most affected by walking alongside, by working alongside, by sharing ethics and values. And we see the sentinel populations that are missing. And there are a range of ethical frameworks that we can use to help rebalance the seesaw. And I hope that over the course of future seminars, we'll think more about that. One of the first practical things we can think about is actively tackling missingness. And that means helping unasked people, answering unanswered questions, looking at policy analysis and dialogue, shifting the gaze, not in a temporary way through applying an equity lens, but shifting people away from where they're not looking the problems straight in the eye and addressing them. Because much of the literature around policy analysis and policy options says that it's ethically and value neutral. It's not. That's a stance. That our research doesn't ignore the populations most affected, that we have the kinds of accords that we have in high-income countries that mean that people who benefit from research think specifically about COVID vaccine and the price that some of those lower and middle-income countries had to pay for vaccines, even though they helped us gather the data that helped us know it was safe and effective. And think about interventions. So the people who are currently missing are those who have most to teach us and most to gain from participating in dialogue, in co-design, and in research. They're also missing from our data. Frequently, in one of my previous jobs, I had to pick up issues where people were missing from the system and enable a way for them to be included. Because I knew that if I found one sentinel person, they were the top of a pyramid of a population of people that would otherwise be missing from our population registers, our health registers, our vaccine registers. So we have to enable the creation and curation of registers and repositories in an ongoing and sustainable way, and not just start from scratch every time there's another emergency or another pandemic. We have, as I've said, changed the relational determinants, change the dynamic. It's not structure or relations, it's both. And we have to pool our expertise and perspectives towards that shared purpose. One of the things that we learned in the ASPHER Public Health Emergency Task Force is that shared learning, shared support. We didn't all go through difficult times exactly the same week. So we could all support and help each other when we were dealing with some really difficult things. And together that should help us not just have a better capacity and understanding of ethical principles and frameworks that we can apply, but help us sustain the capacity and the competency so that we can create those cases for change for what can't be tolerated. And then in reducing the risk of future ethical dilemmas, building that ecosystem that's based on One Health, direct our efforts to building a shared understanding. And the starkest example of this for me is bringing disaster reduction and pandemic prevention, preparedness and response together, rather than having them work in silos. And I know that can be politically difficult, but it's one of the things that in ASPHER we've already committed to do, and we've already established some memoranda of understanding to help us build on the foundations of common interest, recognising the need for a common approach to improvement, the need for common approaches to prevention, and the relationship between patient and population safety. That leads me to think about using ethics to help us think about collective protection, and that impact assessment, avoiding single points of failure, being committed to address what I hope I've shown you is not just an inverse care law, an inverse public health law, but inverse compassion and inverse curiosity, and to create a milieu in which solidarity and reciprocal support are standard practice, so they don't wither when there's government or political neglect of funding or attention. And hopefully some of my expert colleagues can tell me who is the next mentor I should look for in terms of disaster reduction, now that I'm still going back to what Walter Hayes has taught us, which is anticipate and plan for the full spectrum of what can happen. And that means having our values clear. It means having that capacity for difficult and challenging ethical decisions ready, and ways of meeting those difficult things together. Building capacity at community level for preparedness, protection, response, and recovery. And that means thinking about the duty of people and organizations who have agency to support and help those who do not have agency currently to achieve it. It's something that we do when we think about triage in the immediate response to a disaster. We think about who can help others. That was the foundation of a massive community response in many countries to the pandemic, and happens in disasters. That means that you have to have preparedness to be ready for the community response and have a community that has the capacity to respond. So that means addressing these structural and relational things in what my colleagues in other agencies call the inter-pandemic period. We have to work to build equity. Doing that on a daily basis is a practical reminder of our ethical values in practice, and we have to inform, educate, and train the next generation. And a reminder that we cannot improve planetary health without that learning, reflecting, and working together to prevent the next pandemic. Thank you.
Thank you so much, Alison. It was great that you introduced these terms, the relational aspect, working together, again, solidarity. So I'm sure we'll return to these aspects later in discussion. So our final speaker, Dr. Maya Peledraz, and the floor is yours.
Unmute. Thank you so much for having me here. It's absolutely amazing to follow up after Farhan and Alison. We talked before our meeting what should be the order, and I'm just going to roll straight into what Alison just said. So it turned out really great. And I would like to say that I planned on talking about one thing, and then working on it, I got to a completely different place. And I hope you see the right thing. Do you see the full screen, or yeah, okay. This is why I call my talk Learning from the Green Badge on Completely Other Things. What I initially wanted to talk about is about the state's use of its powers, and how ethics actually should fall into that. And I wanted to use the Green Badge as a case study. And this was my initial slide, and I had a lot to say about it. And then again, it got me to completely different places. So let's start from it and then flow with my association stream. So when we're talking about the green badge, and there has been a huge discussion about green badges somewhere at the early 2021, late 2020. This was the scheme, okay? So that was like the big debate that we had to handle back then, which put on the one hand the green badge or the green pass, it was called differently everywhere, that it allows immune individuals to retain their freedoms of movement and gathering, and it serves obviously the public's interest in normalizing a lot of sectors that got badly hit by COVID. And it also serves in a secondary capacity as an incentive to people getting vaccinated. And on the other side of the scale, obviously, we have huge issues of solidarity and trust building, which are extensively harmed by this kind of tool, because you are, well, I don't have to explain it deeply. It's just really clear what happens if, some people are vaccinated and others aren't. And I'm not going to talk right now about what happens even if there's no equal access to vaccination, which obviously exacerbates the problem. But even if you do have equal access, we still have huge issues of what it means to disallow some people, some subgroups, from exercising rights that others are allowed at a certain point to exercise, and what it means to how the public views what the government thinks about them, okay, in terms of governmental trust in them as well. So it goes both ways. So at the end of 2023, we decided to do research and try to, look at those issues from a little bit further away, okay? Because there were a lot of surveys and a lot of research done when the subject was on the table. But we thought that we can gain from some hindsight and a little bit distance from actual events, and also ask people, what do you think you'll do in the future? Okay, so what will happen in the next pandemic? How would you act? Okay, so we basically asked three big questions. We asked them, what drove your actions during COVID? Okay, what did you do? How did you act? How did you react to the green badge that has been in place? And I'll say in a second where. What are your general thoughts about the concept of a green badge, not necessarily in the context of COVID, and how do you think you'll act in a future pandemic? So those were the three big questions, and we used a survey, and again, late 2023, so it's really fresh results. I don't even have all of the analysis yet. And we took representative populations from both Israel and Taiwan. Okay, so that was the big point. We wanted to compare those two. I will not talk about Taiwan. I will talk about Israel because I have initial insights about that. And we basically took over 1,000 representative members of the population and, delved into their minds, asking those three big questions. And that's the general demographics, okay? So quite a lot of female, we wanted to see if priority workers have different notions about green badges. So we asked them whether there were teachers and firefighters and policemen and physicians and working with, in special education places and so on and so forth. And we got 32% of the sample who were priority workers for the in the context of COVID. Okay, they were quite educated, more from the Arab population in Israel than is actually their percentage. And that's because we really wanted to delve into them specifically. So when you look at general statistics here of the whole sample, remember that we have a skewing demographic towards the Arab population. It's important, and we'll get to it next. Not very religious, most of them, or moderately religious or secular, and 64% of them actually got COVID during COVID, and that's going to move us forward. 55% of them were fully vaccinated. Okay, so they got 3 doses of the Pfizer vaccine in Israel, which made them eligible for a green badge. Okay, so if you got less than 3 doses, you couldn't get a green badge. Okay, you could get it by checking for immunity levels, but that was obviously, you had to do it over and over again, but they were not sufficient 2 doses to get a steady green badge. And then we asked them, why did you and why didn't you vaccinate fully? And we got a lot of very interesting answers. And what you see in gray is everything that has to do with using my own autonomous discretion to figure out what's going on around me. Okay, so people did not fully vaccinate because they thought added boosters were unvaluable. And they didn't get vaccinated because they said, well, people who do vaccinate still contract COVID. And they didn't get vaccinated because they thought it wasn't beneficial against new variants, or it was harmful, or there were strong side effects, they were more dangerous, or it was ineffective. Okay, so all of these were the major reasons for people not being fully vaccinated. And then at the bottom, you see a lot of other types of reasons, including, by the way, the fact that they might be concerned about the fact that other countries were not treated fairly in vaccine distribution, okay? But also, obviously, the fact that some of them couldn't medically be vaccinated and so on. But these were like the marginalized reasons. And again, what you see here is just people exercising their discretion, okay? And you don't see here reasons of, well, I thought that drug companies were trying to fool us, or that, well, it wasn't that much that people were going through all sorts of, not just, I'm missing the word, hysterical theories that were completely unsubstantial, but they were looking at information that was out there, and actually some of it was founded on certain truths, okay? And they gave it different levels of power over them, of importance, and they just made autonomous decisions, okay? Which is something that is going to, I'm going to talk about a little bit later again. Then we asked people, why did you get vaccinated? And they gave us, a lot of reasons. that were completely, or most of them were not related to green badges, okay? So most people did not vaccinate because they were forced to. Most people vaccinated because they thought it was important to their health. So again, it was applying their discretion onto the information they were receiving from different sources and making a decision. Okay, so I vaccinated willingly to protect from infection of serious disease. I wanted to protect other family members and people around me, and I trusted the authorities. Okay, so you see, 53% just said I trusted what they thought was the right thing to do. Okay, then you have smaller percentages that said I only vaccinated to get the proof of vaccine certificate. So this is what those initials stand for. It's the green badge, essentially. Okay, I vaccinated so I can travel freely. I vaccinated because my employer forced me, and so on. But those were, like, again, not things that we shouldn't look at. Okay, it actually says that a lot of people were impacted by the green badge, but that was not the main thing. And here again, this is the whole sample, okay? But I want, and by the way, just a little bit of further information. This is collaborated by research from all over the world that pinpoints to that kind of numbers. And I'm just not going to get into it, but this is research that came out from the University of Tokyo, looking at Canada, showing how much green badges impacted vaccine uptake. And this is also looking at other countries where actually green badges had a huge impact, okay? Like in Italy and in France. So green badges do have an impact, but it's not, the bulk majority did not vaccinate for that. And it's more important to look at who from the general demographic were impacted by that. So what comes up from our initial results is that there's a general, well, you can't rely on just giving people information, okay? So if we just think that we're giving people information and they'll immediately understand what we're doing, and what are the dangers, and they'll understand it the way we want them to understand it, this is not going to work. That's not going to move people to action, okay? It's necessary, but it's not enough, because people understand information differently, they interpret it creatively, they seek alternative sources of information all the time, and we shouldn't assume, and that's, I think, a strong point to make, we shouldn't assume that there are like absolute truths that if we project absolute truth, that would convince people to act in the manner that we think is best for the community. And looking back at COVID, and that's, you know, I'm sure you as health professionals have felt that as well. We tended to describe things as absolute truths because we thought that way people would be convinced. And we were hesitant about telling them where we are debating within ourselves and where we don't know things, okay? And that's not to say that we shouldn't make decisions, okay, or even use powers when we think that, you know, regardless of the things that we don't know, this is the best course that we can take. But we should tell people that we took that course of action, despite the fact that we do recognize things that we don't know yet, and we might be wrong. But this is the best thing that we can do at this point. And I think we should be quite clear about that. Other things that came out from the research is that there is broad support, actually. There has been broad support, and there is broad support towards future use of green badges because people do believe that they improve safety and protect vulnerable populations. But this broad support is especially centered around healthcare settings. Okay, so it's less clear if you look at cinemas or restaurants or stuff like that at the broader economic and cultural spheres, but really looking at how we can protect the most vulnerable. We do see broad, again, broad acceptance of it in future inclination, okay, as future inclination. And we asked them, do you think it is an acceptable tool looking forward? And a lot of them said yes. And then when you look at extreme outbreaks of pandemics, okay, so peaks of pandemic spread of waves, you see really high acceptance rates, okay? Okay, so this is the general sample. But, and here I want to move into another thing, you see a huge difference in Israel, and that relates to what Alison was talking about those groups that are missing, that are not participating in the communal effort, okay, that we don't see them on the vaccination registries. And in Israel, one of those groups, which we're interested in specifically, is the Arab population. Okay, so the Arab population in Israel, within Israel, you see a huge difference in their support of green badges. And you see that going forward through the whole, throughout of all the questions that we asked, okay? So mandating green badges will increase my inclination towards getting vaccinated in the future. The general answers were quite positive. In the Jewish population, you see a lot of support, and then you see this huge drop in support when you look at the Arab population. When green badge is required by the authority, I will not get it and will be willing to bear the consequences, okay? 42% of the Jewish population said, no, I'll get on the wagon, okay? If it's required, I'll do it. 21%, only 21% of the Arab population said that, okay? So you see a huge difference in perception of green badges when you look at subgroups, okay? And I will not get into, you know, the other data because it's just tiresome, but you see those drops all the time. You see for every question that we asked. So where am I getting to? What I'm trying to prove, to say here. So generally speaking, green badges are a good incentive for those populations who are already on the wagon. Okay, so obviously in the, let's call them majority groups right now. Okay, so in the majority groups, you see more vaccination to begin with, and then incentives work on them more. Okay, they are more inclined to be impacted by those incentives. And I think that incentives just intertwine into already existing notions of distrust in the authorities and into notions of separateness. Okay, so those groups who don't feel solidarity in everyday life will not pitch in when we called for their solidarity in pandemics, okay? And green passes will not make a difference there because it actually tends to, because of their solidarity and distrust core problems, okay? They actually tend to heighten those aspects that those subgroups suffer from to begin with, okay? And in that sense, we do not, it's not a good targeted a tool because it misses the groups that need to be harnessed, okay, that need to be enlisted into this huge endeavor more than everything, and this kind of misses them either completely or to a greater extent than those groups who are already, you know, mostly with us to begin with. Now, this is extremely interesting, looking at that data regarding the Arab population in Israel, because when you look at regular vaccines, the Arab population in Israel is one of the groups that has the higher vaccination rates, okay? So it's not that they are anti-vaccines or vaccine hesitant in general as a group. That's not the issue here, okay? Something else is going on, and that thing is, again, notions of lack of solidarity and lack of trust in authorities to begin with, while there's a huge trust, or there's a basic platform of trust there in the health professionals, okay? So when you ask the Arab population in Israel, why do they vaccinate for regular vaccines? It's because they trust their nurse, they trust their physician, they understand from those alternative sources that this is important, and they vaccinate. So it tells us, first of all, that trust is extremely important. If you don't have trust initially, those kind of incentives will not make a difference. And that, you know, looking at what I just told you about the Arab population, there's this need for another basis for guiding behavior and decision-making if you don't trust the authorities. Okay, so if you don't think that what your authorities are telling you is what you need to base your decisions on, you look for other bases for decision-making. And in a lot of cases, and I don't think that this is unique to Israel, you see the health professionals as this alternative basis. And what I want to actually stress now, and this is the point I was trying to get to all along, is that we need to put a lot of effort into harnessing, into employing, into getting the health sector on board with our efforts, because they are the ones who can have a huge impact on those subgroups that do not trust the authorities, that do not feel solidarity with the greater community. And there are a lot of ways to do that, starting from medical schools, and I'm going to talk about that in a second, going forward into continuing education of health of people who are already in the professions, and obviously looking at health professionals as a unique target group during pandemics as well. Okay, but that's not enough. Okay, if we wait to get them on board, to make them our partners, and to harness their ability to help just, you know, people in the community make better decisions, we need to start now. Okay, so this is the new normal. I'm closing the circle here. The new normal has to put a focus on those sectors, on physicians, on nurses, and to get them to be public health agents, because they're not right now. And that's the point I want to get to. And this is what you're looking at here, okay? This is a thesis that one of my thesis students wrote under my supervision. And what she was interested in is looking at the public health education, and specifically public health ethics education in medical schools. And they are slim. they're specifically slim in those things that we think of as public health, education, and ethics. Because what you do see in medical schools is a lot of public health tools. Okay, so we teach epidemiology, we teach biostatistics, and when you ask a lot of medical educators, you ask them, do you have public health in your medical schools? They say, of course we do. Look, we teach epidemiology, okay? Yeah, but that's not the point, because you know that public health is not just tools. Public health is a view on life. Public health is a different way to look at the world. It's a different lens of analyzing what's important, okay? And if we don't teach medical students, we don't teach nursing students, we don't teach them public health in the broader sense of what it means to work for the community, how we can better their life through bettering the health of the community. If we don't teach them that, the fact that they know epidemiology, that's not going to make them our partners. And you know exactly like I do that a lot of physicians, if you go and ask them, should I take this vaccine? They have no idea how to answer that question, because they never got the sufficient education to actually answer that. And sometimes they don't even know that that's the case. And sometimes they don't feel comfortable to acknowledge that. And they give the public wrong answers, okay, and wrong advice. And the public doesn't know that it's getting wrong answer from people who have incomplete education, who don't know public health. Okay?
Maya, I'm sorry that I'm entering, but
yeah, I'm
you are
like
15 minutes late.
No, I'm
15
we
minutes
are
late.
15 minutes late.
Yeah.
But that's okay. No, so what I want to say is that just this is not a unique thing to Israel. I hope that you see this as well. So this is an article from Medical Education that came out just a few months ago, talking about this exact thing in American public health, where medical education missing out on public health perspective on life. So this is what I want to use every day, regular days now that we are not in the midst of a new pandemic to do. We need to better the understanding of public health in our health professionals. I think that will make a huge difference in how we later on get the correct or the good, healthy response from our other groups, from the subgroups that are not prone to trust the government, to trust authorities. It will make a huge difference. So thank you so much.
Thanks a lot, Maya, and thanks for all speakers. So we're going to open now the floor for questions. I want to bring 2 points that I'll be happy for all speakers maybe to reflect. One is the question of solidarity that emerged, I think, in all your presentations. Solidarity is always mentioned as an important value, but it can be very tricky, because solidarity can also means that I'm in solidarity with people that are close to me, looks like me, so it can be even racist in a way. There can be other questions regarding solidarity between what kind of different groups. It can be also solidarity within the public health workforce. Sometimes there is a discrepancy disconnect between the managerial elite and people that are working in the field. I think during COVID, especially at the beginning, people felt that they were abandoned without having enough protection, PPE and masks, etc. And the second part is related to the question of all of you are now and also heard your teaching. It was reflected also in your presentation, the way you are discussing it with your students. And I wonder what's your take, how to make public health ethics more central to, I think, Farhang, you presented maybe the less optimistic, I mean, a very fierce call for making a change here. Maya, you presented empirical bioethics. I know that the three of you are also engaged with it, and that's also an important aspect, and that can also engage. So the floor is open, and I don't know, Tom, if you want to add something, or Meng, before we open it for other people, and also we'll give each of the three presenters to react and give their final conclusions.
Nadav, I was only going to say that if people are happy, given the conversation, maybe we go on to 5 o'clock and colleagues can stay with us if they want, but we could continue the conversation for a bit longer as well if there are a number of questions. I may have just tempted fate there and there'd be no questions, but I don't think so.
Perfect. I see Carlos Alberto here writing, is it really possible to talk about lesson learned? If so, in a world of irrational competition and power struggles, how viable is to think or be certain in the lessons will be applied? I think it's an interesting question as well. Maya raised the issue of trust and mistrust. Yes, Meng, please.
I guess I've got a fairly practical mindset, and I love the richness of the discussion, and I'm being totally struck by the science and the thinking behind ethical considerations. Now, my experience of ethics has largely been around research ethics, and I know that it often is the one thing you need to achieve before you can get anywhere. But I think the same should apply to what we do in public health, because there are all sorts of actions that we take, which we find further down the road has unintended consequences, like screening programs for bowel cancer. Who will have thought that actually then creates inequalities because of the differential uptake? But what's really important is that the ethical considerations are taken right at the beginning. So my practical question to all speakers is, in the real world of operationalization, how do we bring ethics into the daily practice of our professions? And given that ethics, and the difference between ethics and morality is that morality is subjective, ethics is perceived to be more rational and objective. So what is the underpinning public health ethics framework that is objective and rational that we should be applying? Or is this what we're trying to create here?
This is a great question, and probably I'm sure that I have a lot to say about it, but I'll keep myself. And let's start first with Farhang, maybe.
I think this is at the heart of actually what we're trying to discuss and try to do a case study in pandemic, because I think we did the lessons learned from pandemic, how come it's going to moral disaster and so on. So just to address the three different questions which have come in. One is the issue of solidarity. I think there was a workshop at the UFA conference in Lisbon a few months ago, and I think the word has been tainted because so often it's seen as a left-wing issue, and public health people are accused as being so left-wing. And I think language is very, very powerful here. And the Public Health Ethics and Law Network has actually began to develop 10 key ethical principles in getting ethical practice. And I think this has just been published in the Journal of Public Health. I'll share that through INIS. And I think language is very critical. And although in the definitions we have used solidarity, we haven't used this as one of the core principles, largely because I think historically, and I've talked to Barbara Prensek and Haggai about this, who are doing a major research project, how to teach it. So I think the issue of solidarity is good as public health professionals. We see that. how to get this into practice. I just want to develop a case study in the UK that, in fact, as part of the public health training program, I think we need to be strategic about this one rather than just be philosophical, as Professor Cow has said. So as part of the review of the public health curriculum, public health ethics and law was as now considered as a core competency, and all public health people in the training program are required to do that. This has been taken up at the GMC, and this is going to be now taken up for other professions as well. But not only have we got it in the curriculum, now there's active work to actually develop training, education and training and so on. And ASPHER has also taken this issue up as looking at accreditation of training program, being political about this one. If we're going to spend our money to train public health, do the current MS Masters program teach ethics and law adequately? Our current evidence shows no. Often it is a voluntary module done by amateurs in a very short period of time. I've done longitudinal surveys. There was an ASPHER survey of all schools of public health. And now we're talking. So I think we need to be not just philosophical, but be practical. And I think there are ways and means of doing this. And a recent article in the Journal of Public Health will actually highlight the current experiences in France also. I know there's been a piece of work around ethics over a 1-year period, and now they're looking at this strategically, how to do this. And the issues are a code of practice in the good practice guidelines in the UK. These ethical principles are now a requirement for us to be accredited. So there's strategic ways of and to get this centrally, I think education and training are central to this, but also with policymakers. In the UK, for example, there's been work done with ministers about discussing about the nanny state so they could test their assumptions. This has been done quietly because 2 of our new block of MPs in the UK are, and this has also been done in a European sort of way. I love the comment from Carlos Alberto Marin, and perhaps he'll contribute to this. So I know Jean-Claude would like to also talk about the French experience, with the chairs may wish to take on, because they've done an excellent piece of work and a wonderful report.
Thank you, Frank. So before we move to the next speaker, Jean-Claude, please unmute yourself.
No, thank you very much. No, I didn't want to speak about the French experience. It would take too much time, but I have, and we are, the time is running, but I have a very specific question to Maya, and thank you very much, Maya, for sharing your experience regarding vaccination passes. We had the same experience in France. So Finland say we should include ethicist or ethical dimension at the start of the thinking of working on a public health issue. So in your experience, what's that question raised at the beginning of deciding whether or not to have vaccination passes? I'm pretty sure of the answer. And the second one is based on your experience and the evidence that you very well illustrated. Would that be in a new pandemic or a new similar crisis? Would you think that the public health authorities of the Ministry of Health would be inclined to include the ethical dimension in the analysis of the issue and take it into account with ethical dilemma? Because what you showed is a very nice dilemma between 2 values in competition. So yeah, so that's the question in practice. Did you learn from, or did the public health system in Israel learn from that experience? Thank you.
Oh my God. So I think we will have to at some point bang our head against this wall that's called politics, because and that comes back to what Meng said. We can talk a lot, and then politicians will do whatever they want, sadly, and we can have one administration that's more open or even actually interested in an ethical debate, and another that's completely disregarding it, and nothing we do will have any kind of impact. And sometimes, and I think 2022, we had a conference in Basel of the IABA, and we had a session there about with people who actually sat on as ethical advisors for the government, for different governments. And there wasn't even one that wasn't extremely frustrated, okay? Because even if the government asked them to come on board and serve as experts, their opinions were generally disregarded, okay? So that's the broad answer. And I don't think that's going to change looking forward. It's a chance of what government you're getting in the next pandemic. Going back to your question of, did we look at I'm not a part of the Ministry of Health, but I am sometimes consulted, and I did sit on the national, Nadav, what's it called? We're both a member of the National
Health Council, the Health Council.
The Health Council. Okay, good. I'm sorry. It's because I'm jittery. So I can tell you that the questions were raised, especially within the ministry and within the relevant, within the public health administration. Okay, so they were raised, and for example, the main, I think, point that was important for us to stress is that this is not done for the sake of acting as an incentive, okay? But rather that this was the least intrusive, the least restrictive measure that can be taken in terms of the infringement on the rights of those people who are already vaccinated, okay? So you can't continue to use closures. You can't continue to forbid them from using, cinemas and restaurants and so on and so forth, while they are already vaccinated and pose no threat to the general public. So, and obviously it allows for us to start moving the different sectors for the benefit of everybody. So that was, I think, the main point that the Ministry of Health was trying to come to bring across. And then different people in the government kept talking about incentives. So all of this good work that we were doing, really thinking about how to frame it and what are the different considerations and really trying to get to an ethical, at the end of it, an ethical decision. It was kind of undermined constantly by different politicians that kept talking about incentives and criminal, repercussions and so on and so forth. And so it's kind of, it's not easy to be a public health person. It's a grueling, I think, job that we took on ourselves. Yeah.
Agree.
Thank you, Maya. So, Alison, we are kind of close to we can have some more time, as Tom said, but if you can have some more thoughts.
So I guess in terms of Meng asked originally about ethical frameworks, and I guess the more I learn, the less I am convinced that one framework is enough, and that we have to be continually learning and refining our approach and being honest with people, that we don't have all the answers, but this is the best of our thinking. This is the best of our thinking now. On a practical basis, I think I said that I think most people, the thing that is in their mind is we must do more good than harm. And if I had one sort of mantra, that's what it would be. That's the place that we need to, that's the place that we would start. I think it's also important to remember that not all countries have public health laws that support them in times of difficulty. And I know that although some of it was overridden, the Public Health Law in Scotland and the NHS Act and the parallel acts in education and local authorities gave us quite a good basic platform and experience on a day-to-day basis of knowing when you needed to isolate and quarantine people. It gave you the opportunity for individual or family compensation if it was necessary, and it gave you the opportunity to do things on an individual outbreak way. Some of the ethical dilemmas arose where what we could practically do, practice doing, and were able to do could not be scaled up because we needed that political support. And so what we could do was sometimes successfully, sometimes not successfully, ensure that we had ways of collaborating and organising with each other that gave us the best chance of at least making a good case to the politicians. And the training thing that I would add is that I was taught how to break down walls, how to create doors where there are none, how to create windows where there are none, but not how to cope with it being as if you were invisible, how to cope as if you were bashing your head against jelly that just bounced back, and it was as if you were never there. And I think that's something that we have to include in our training, particularly, for example, given the dilemma that people and the moral distress that I reckon that people who are actually doing the hard work on the IANB are probably facing at the moment. Thanks.
Thanks so much, Alison. Indeed, more moral distress, as Farhan presented and you also raised now, is I think extremely important. I see here another additional comment. Learning lesson does not necessarily mean that they are used in the best way. In the future, the technical, ethical, or advocacy reference in public health at a high political level, not only to maintain, strengthen what was done well, but especially to avoid repeating the same mistakes. I totally agree. I want also to refer you to a nice publication by my friend, colleague Itai Bavli on public health mistakes and how to deal with them. I think all of us can agree that even with amazing intentions, and sometimes intentions are not so good, but let's say many of us try to be really working and doing the best in a state of uncertainty. We definitely can recognize now many mistakes we did. And I don't think that we are teaching enough how to deal with those mistakes, how to make apologies. In the past, there was discussion, for example, about HIV/AIDS and blood donations, or ring worm irradiation, or many other things. And Tuskegee, this is going back even farther, and how to recognize this wrongdoing, especially, Alison, as you mentioned, if there were population involved that were transparent, so invisible. That's very, very, very hard. So are there any final questions? Okay, so thanks so much. Thanks again, Tom, for working together on this, and thanks also, of course, the presenters. And I think we can all agree, and thanks, Meng, of course, for giving us the opportunity. And I think it seems that there's still so much to cover. So hopefully we are going to have more webinars covering other aspects, such as research, for example, and bringing other empirical bioethics examples and teaching methods, simulations, etc. Thank you so much. Tom,